Thanks. It's a pleasure to be back. So I'm just going to give an update on this approach, and for anyone who hasn't heard of it, the concept behind doxorubicin eluting embolization therapy for desmoid fibromatosis is based on the following. So okay, so we're leveraging two features. On the drug side, doxorubicin is a good drug for desmoids and not a great drug for the rest of the body. Fortunately, its chemical composition is such that it has a protonate and amine group. It's it's positively charged. The part that's active is red and positively charged, which means that if you kind of sprinkle microbeads, about 100 microns, which which are generally made of polyvinyl alcohol and sulfate covered, they're negatively charged. You have an ion compete process, and the drug will bind to the particles as they sink into solution. Okay, so we're leveraging that, and now we're leveraging the fact that desmoid tumors are hypervascular. So they're requiring that they draw more blood than their adjacent normal tissue. So if you're an interventional radiologist, and all you know how to do is navigate through the body using arteries, we want to go and find what is the vascular address of this tumor, and then can we direct these doxorubicin-laden particles into the tumor, delivering a high dose of the drug into the tumor with minimal systemic toxicity. We wrote this protocol in 2014, published our first case series on 4 patients in 2018, and then began a prospective study. And then, the kind of cat was out of the bag. I was speaking with French too much, and other colleagues from Memorial, from LMU, did their own, and we ended up with a combined prospective retrospective study that we published in 2022. So I'm going to show you the results of that first. And what you'll see is that as it is 2/3 of the patients were women, we treated about a third of the patients, a third of the patients had tumors in the chest or abdominal wall. Another third had tumors in the neck or the shoulder and the axilla. We had 3 patients with mesenteric tumors that were treated by finding the tumor blood supply from the superior mesenteric artery. In all cases, in one case, there was additional supply from a parasitized testicular artery, and 1 patient with a mediastinal tumor. Tumors were large, so small tumors, we generally use cryoablation to treat them. So the average size in terms of maximum length was about 10.5 centimeters from 9 to about 14. Tumor volume on median was 310 cc. About a quarter of our patients did this as first-line therapy. That in Israel, that's now pretty common. Our sarcoma community we do watchful waiting, and then often resort to DEE for patients with tumors, especially on the extremity or abdominal wall, chest wall. 33% had prior surgery and 67% prior systemic therapy. The time from diagnosis to treatment was about 2.5 years. And the number of treatments per patient, a median, was 2. So the range was 1 to 4. And the total dose of doxorubicin per treatment was around 49 milligrams, with a total overall of 75 milligrams. And what this implies and what's true is that generally these patients on their first treatment will get a larger dose of doxorubicin than they will on their second or third treatments. Okay. So our image-based response, because we had patients who we had a smaller group that where we had more than a year of follow-up, and then a much larger group with shorter intervals of follow-up. If we look at patients with more than a year of follow-up, we had 71% with a partial response, stable disease, and 29%, and no patients with progressive disease. For those who had less than a year of follow-up, we had two patients, 13% with progressive disease, stable disease in 10%, and partial response, in 63%, and a partial response in 25%. This is what the waterfall plot looks like in terms of RECIST. And if we look at volume, and this is important because RECIST is not always, if you have a long tumor that gets skinny, its RECIST will remain the same. And so again, it is better to use volume, and it is better yet to use T2 signal intensity. But our volume plot looks like this with a median drop of volume of 82%. And the red are patients with a less than 1 year follow-up, and in blue are patients with more than a year follow-up. In terms of safety, we had one grade 3/4 adverse event, which was a neurovascular injury. And in terms of any adverse event, about half of the patients had significant post-embolization pain. Usually that lasts for about a week. Skin injury, 42%. And then fatigue, 21%. Neuropathic pain, 17%. Reopening of wounds, 13%. And that is somewhat intuitive. People have had previous biopsies or surgeries. We're targeting fibroblasts. These are desmoid tumors are well-differentiated fibroblasts, and those which have, who are, not the culprits, but are involved in sealing the injury from prior surgery or biopsy are involved as well, and you can get reopening of those injuries. Local alopecia, 8%. A second study, this is a study that was done on 11 women with a relatively short follow-up interval, but the advantage here was that they were all done within 6 months, came out of Memorial Sloan Kettering. Average volume reduction was 18% at 1 month and 38% at a median follow-up of 5 months. At 1 month, 6 patients, 54%, had reported improved pain. And at the latest follow-up, 10 patients of the 11 reported improved pain, except 1 patient did not. So on the basis of that, we are beginning a multicenter prospective study. What's missing is that what we're seeing are a larger case series or a combined prospective retrospective study where that particular study, more than 70% of the patients were still done at one institution. And in order for this protocol to be more widely adopted and for there to be a higher level of comfort both by the operators and by the referring physicians, we need a more standardized protocol and consistency of results across multiple centers. So the plan here is 40 patients, 5 institutions. And the primary endpoint is 1-year objective response rate, which scientifically goes against what I was just saying, but it is still the standard that we can use to compare to other studies. We are also evaluating T2 response, volume, and patient-reported outcomes. I want to just address that the approach here is a DE therapy and then an MRI performed 2 months afterwards, a month or 2 months after. Now, what we're looking for is circumferential change in T2 signal. And if we see that, we don't go on to a second or third session. And that's just because over the years, that's what we've observed consistently as being an indicator that the tumor will continue to regress. Back to some of the things we spoke about earlier, there seems to be an off signal. If you get if there is a 70% circumferential decrease in T2 signal with one region that isn't covered or treated, you will get progression from that area. So we've allowed up to 3 treatments over the course of the year. And that's the study. Thanks for your attention. I'm happy to take any questions. Questions? Go ahead.
Are you planning on using Goddess for
Yes,
the study?
we are. Maybe can you come closer to the microphone in case people are in line so they can hear? Just leave it somewhere.
Do you see an advantage of a doxorubicin beads versus just planned embolization for this
Absolutely. I feel very strongly about that. So the goal, so in the terminology of interventional radiologists, we want to, it's called pruning the tree. You don't want to get stasis. The goal here is not to block the blood supply to the tumor because the tumor is really much smarter than that. And if you block those arteries that are supplying it, it will find alternative smaller arteries, which you will not be able to cannulize the next time around. So necrosis is not our goal. Our goal is drug delivery. This is about doxorubicin and not about ischemia. Yeah.
Should you deliver a gamma secretase inhibitor?
Um, I think it's a fantastic question, and I think that, look, I mean, the history around doxorubicin eluting beads is that, in 2002 we had Lowe and LeVay. The TACE, trans-arterial chemoembolization, started off in the liver, and as it turns out, it didn't really matter what you threw in there, which chemotherapy, and whether you used gel foam or beads or Lipiodol. But what happened was, fortuitously, there's a drug that you can load on a bead. It happens to be doxorubicin. As it turns out, there's a study in JCO from Memorial, Karen Brown, a randomized prospective study that showed that there was no benefit in HCC between using bead block, regular beads, versus beads with doxorubicin. It makes sense because no one uses doxorubicin for HCC. But hey, doxorubicin works for mesenchymal tumors. So that's the idea here. Now, if we knew how to bind gamma secretase inhibitors, or for that matter, if we knew how to get doxyl, liposomal nanoscale particles, to localize with an arterial infusion and avoid kind of a first pass miss, then that would be even better. So the short answer here is absolutely, I'd love to do that. There's a big question about what about infusion of something like gamma secretase inhibitor? What is the first pass uptake? Can you optimize that? Because if we could, now we could deliver this kind of therapy to patients with tumors in the head, in the neck, where non-target embolization is just unacceptable. And that, that's, I think, looking forward, we want to leverage vascular access with the appropriate drug. All we have so far is doxorubicin on beads, but it's a good start.